Det at falde er et stort problem for patienter med Parkinsons sygdom, og ikke mindst med de klinikere, der skal forebygge og behandle det. Derfor har vi inviteret professor Nir Giladi fra Tel Aviv Sourasky Medical Center i Israel til at tale om dette emne. Hello, Professor Nir Giladi. Thank you for being here with us today.
Thank you for inviting me.
Before we start, Professor Giladi, would you please briefly introduce yourself to the audience and your expertise within Parkinson's disease?
So I'm a neurologist. I'm the chairman of the Neurological Institute in Tel Aviv for the past 15 years. This is the biggest institute with 55 neurologists in all disciplines of neurology. I've been working with Parkinson patients since my fellowship back in New York in Columbia Presbyterian, under the guidance of Professor Stanley Phan, the founder of the Movement Disorder Society. This was now 30 years ago. And since then, I've been seeing many patients and running multiple research studies. And now also heading a center within the Tel Aviv University for the prevention and treatment of Parkinson's disease, called the Oftin Center.
We're here today to talk about falls amongst patients with Parkinson's disease.
So fall is one of the most important motor complications of Parkinson's disease. It is very frequent as the disease progresses. So when one talks about incidence, it depends on what population you are looking at. In the very early stage, especially in younger patients, we rarely see falls, but as the disease progresses, they all fall. It's just a matter of time. In contrast to the younger patients, the older patients, those who start the motor Parkinson over the age of 70 or even 75, they frequently fall as the first motor symptom. This is how the Parkinson presents, which is very different. And altogether, I think that all patients with Parkinson, if they will live long enough, will fall. Usually after 15 years, almost everyone falls at least once, and most of them even many more times than once a year. Very common, and this is the leading cause for death of patients with Parkinson's disease, because the consequences of falls are terrible. Which also brings a very important issue, because falls not always lead to injury, and only few falls are leading to injury. And we never know which fall will lead to the head injury and the intracerebral hematoma. So this is like a Russian roulette. You never know when the bullet will come up. So falls have different consequences. The immediate ones is depending on whether you have been injured or not. But as we've discussed earlier, the occurring of fear of falling, the anxiety that comes with a fall, is a significant consequence. We see patients who had one fall and then they never leave the house and actually practically in a wheelchair. And others who fall 10 times a day and they will continue doing their daily chores and activities and taking the risk without any fear. But we have to remember that beside the injury or the fear of falling, a bad fall can cause head trauma, intracerebral hemorrhage, subarachnoid hemorrhage, and death. It can cause hip fracture, operation, and late complications that frequently leads to death within a year. So I use, when I discuss falls with my patients, I say that always that it's something that you have to prevent in order not to be sorry about later. because when you are lying in the neurosurgery department with intracerebral hemorrhage, you can only think what could you do, what could you have done to prevent the fall, but this is too late. And it's the outcome that counts. It's not a goodwill is not enough. We have to reach 0 falls, and this is not just the person with Parkinson's task, but the entire family and those caregivers who are taking care of the patient. Because at the later stage, usually you need another caregiver to help you prevent additional falls.
You already mentioned that this is a motor symptom. Are there also non-motor contributors to falling in Parkinson's disease?
Absolutely. I think I would go even further. I have an editorial written several years ago. The title of the editorial was that a fall is a cognitive failure. Trying to stress the fact that as long as you are aware of the risk of falling and you are doing all the precautionary steps to prevent the fall, you will not fall. That means that if you feel unsteady or unsecured, you will use either a cane or a walker or a wheelchair, because practically from the time we were animals, if you fall, you die. The other animal will eat you. So we do not fall. We should not fall. And if you are cautious enough and you are aware of the risk, you will use all the precaution steps. So, to my opinion, cognitive aspects are extremely important for increasing the risk of falls. And this is mainly related to the frontal lobe and this executive syndrome, with a careless behavior, with problems with dual tasking, with problems with attention, with calculating the risk. So it's a high level cognitive function that are tightly related to fall risk.
And what do patients feel about this? Are they concerned about falling? How does it affect them in the way they go about their daily life?
So it's a very interesting question, because when you diagnose a patient with Parkinson, one of the first questions that they come up with is, when will I be in the wheelchair? So they see the risk of losing mobility and losing a wheelchair as the devastating outcome of Parkinson's disease. But as the disease progresses and the cognitive function is decreasing, and their executive functions are not as sharp as they used to, they become careless. And in spite of understanding the risk of fall, they are not using the preventive approach. So patients are aware, intellectually they understand the significance, but very frequently, especially in more advanced patients, they do not really implement the cognitive understanding into daily life, a preventive approach.
Do patients with Parkinson's disease discuss their falls or their near falls with their treating physicians?
This is an excellent question, and it does raise a very important point about the near falls, or as we call it scientifically, the missteps.
Missteps.
So those are, first of all, this is a very important risk factor for future fall. Like the most significant risk for falling is a previous fall. So a very significant risk of a fall, of the first fall, is frequent missteps or stumblings. And I think that patients are underreporting their falls. They tend either to forget or to dismiss or to downscore the significance of the fall if they haven't been injured. and they never report about the missteps. How do we know that? We are now, for many years, actually, more than 15 years, we are sending patients home with sensors that are sticked to their back for 2 weeks. And we count missteps and actual falls. And there is a huge difference between what the patients are reporting and what we see from objective sensory measures, or sensors measuring acceleration and actual falls. So in the clinic, when we ask the patient, has you fallen, or have you been ever experiencing missteps, we get answers that are not reflecting the real life.
That is extremely interesting. Are these objective tools, are they commonly used amongst neurologists, clinicians who treat patients with Parkinson's disease?
So this is now the whole digitized health world is now in fast accelerated mode. Many of us are now using those digitized watch that can detect falls. All the watches has their accelerometer built in, so it's easy to detect. In clinical world, I think there's been a very big study ran by the Michael J. Fox about over 1,000 patients who use those watches to detect falls and other mobility issues. I know about other studies that have used this kind of digitized sensors, but it still hasn't been used as a routine measure of mobility or safe mobility at home in the large population or the Parkinson population.
What can patients with Parkinson's disease do to prevent falls?
So I think the concept of preventing falls has to be discussed from the time the diagnosis is made. It is especially true when you deal with older patients, but it's true throughout the course of the disease, because, as I said, the fall is a terrible complication of the disease. And in order to avoid falls or delay the first fall, you have to work out right from the beginning all the risk factors. And there are many risk factors for falls, starting from the simple visual issues, vestibular issues, general health issues, cardiopulmonary problems, to, as we discussed, cognitive and affective. You know that depression is a very significant risk for fall that has to be treated. Anxiety, sleep problems like obstructive sleep apnea is a significant risk factor for fall that has to be detected and treated not after falls has occurred, but years before, in order to prevent the fall. So there are many measures, as well as a polypharmacy and other comorbidities, but also directing to the motor aspects that are responsible for safe locomotion, like physiotherapy, general daily exercise, make sure that you are well controlled by medications, because we haven't touched it yet, but for example, freezing of gait is a significant and very important risk factor for fall that should be prevented or delayed as much as possible. Altogether, I think the approach should be to treat all risk factors years before the first fall. I think this is the whole art of treating a patient with Parkinson's disease, because you have on one hand to treat the symptoms and give them the best quality of life. On the other hand, you don't want to expose them to side effects or to late complications. So it's always a balance between function and the potential risks. There is no one solution for all patients. And this is a good opportunity for me to raise the issue of personalized approach. I don't think there is one approach that fits all. In order to decrease falls or prevent the first fall, and this is what I wanted to highlight, that once a first fall occurred, the next one is just a matter of time. We should work out to delay as much as possible the first fall. And this is by treating all risk factors at the same time. And as I said, for one person, it's treating the depression. For another one is focusing on the exercise aspects. The third one is treating the sleep problems or the polypharmacy or the diabetes or the hypertension or hypotension. So there's not one solution, but we have to personalize our approach based on the specific aspects of the disease that the patient is experiencing.
And this brings me to my next question. Does advanced therapies such as deep brain stimulation or continuous dopaminergic stimulation have a role to play in improving the risk of falls in patients with Parkinson's disease?
So I think it does go on the same lines as we discussed before, that you have to give the patient the exact or the best solution in terms of his or her specific disease. If a fall is improved by levodopa, then continuous dopaminergic stimulation is an excellent approach because you decrease dyskinesia and decrease off time, you decrease freezing, and you decrease falls. If the patient is worsened by levodopa and develops dyskinesia or freezing or cognitive changes or somnolence, then you have to be extremely careful with medications and continuous levodopa as well. The same rules fit the deep brain stimulation. If the gait problem and the freezing is levodopa responsive, deep brain stimulation is an option. If we mentioned earlier that cognitive decline and dysexecutive syndrome is a very important risk factor for falls, and if the DBS is worsening the executive functions, then DBS is not a good option for such a patient. And I think this is what I love about taking care of patients with Parkinson's disease. You have to really get for each patient the best solution, and it's never the same. And I can share with you, I see about 40 patients with Parkinson a week, and none of them is the same as the previous one or the next one. We use drugs, but we have to be aware that many of the drugs that we are giving are frequently increasing the risk of falls. And we are not aware enough of the fact that anticholinergic drugs, benzodiazepines, sleeping pills, many drugs that are dropping blood pressure, all those are important risk factors for future falls. So it's a delicate balance between the positive and the negative effect of drugs. And the other question that I frequently ask is whether treating cognition will decrease fall risk. So on the scientific level, this is probably true, that if we give either cholinesterase inhibitors or even methylphenidate like Ritalin, or drugs that are improving cognition and alertness, we should decrease falls. I must share with you that practically on a clinical ground, it usually doesn't work, but it's worth a trial.
Professor Giladi, thank you very much for your time today. This was a pleasure having you with us. Thank you so much.